How you guys doing out there? It's Douglas Simon D. Shea for Centric Health TV, and I'm joined by Richard for another Think Big, Act Now session. And this one is going to be doubly fun. Don't you think so, Richard?
I think so. Having two guests is an absolute joy. I'm delighted this afternoon. So yeah, I think we can really go for Think Big, Act Now. And a different dimension today. I think we're coming in with VitalHub. We're looking really therefore, our starting point's data, a massive bit of our work all around digital for all of us in this area. So my understanding is they're about integrating data, sort of looking at patient flow, giving a sort of simple one view of everything that's going on. Yeah. But my view is let's go over and see them and find out what's going on and what they really do and what they've really learned over the last year. Should we do that?
Absolutely, absolutely.
Let's go.
Hi, Lisa. Hi, Pete.
Hi.
How you guys doing? You all right?
Good, thank you.
Good, good. Just as Richard teed up, all this data, what do you guys actually do? Data makes sense.
I'm going to interrupt you first. Who have we got on screen? We don't know who they are or what they do.
Oh, sorry, go on.
You're so keen. Chill. Lisa, start. Ladies first.
So mine's a bit of a mouthful. So I'm Lisa Riley. I'm a clinician. So I've been a nurse for 23 years. So most of that obviously in the NHS. Been a senior manager for most of that time. Spent a couple of years in NHSI. Looking at improving patient flow, typically in urgent care. So elective is a new area for me that's been a real eye-opener, which has helped. It's really helped because we've had to really get under the skin and try and understand it. And I joined Transforming Systems, which is now under the umbrella of VitalHub, about 3 years ago. And I'm now Vice President of Strategic Product and Partnership Development. I do need to get that changed because I cannot say it.
Yeah.
So I oversee all of the 4 companies under the VitalHub umbrella, which all deal with the patient flow side.
Brilliant stuff.
And Pete?
My job title is much easier. I'm the sales director. So I've spent all of my career in health IT, trying to help the NHS improve things. So for the last 8 years, I've been working for InTouch with Health. So we specialize in patient flow management. We're live in well over 100 NHS trusts, and yeah, that's what we do.
Brilliant, thank you.
VitalHub is an amalgamation over in the UK of a number of tech companies. So there's 5 of us at the moment under one umbrella of VitalHub, but we've all kept our own identities. We were all formed, all got our own credibility and reputation from what we do, and we do integrate data, but we take data from all the different elements and areas where it exists and all the weird and wonderful ways it's stored. And we put it in one place so it does tell one story and it simplifies it for the users. Essentially, it's all about patient flow. It's about getting that movement of the patient for their experience and their outcomes so that it's a better journey. And it's safer. It's safer for the patient.
Absolutely. Then, and that sings to my heart as well as a clinician. That single view is so vital, and as patients move from different environments, being able to track them. Can you say a bit about integration and the whole interoperability? Could you just kind of break down the fact that you've got data coming from all these traditionally siloed repositories? How do you bring that together and present that in a single view to enable better patient care?
First of all, we've got a very clever tech team. Multiple tech teams. I suppose we need to point out, whenever we talk to people, we do say we don't go in and try and replace systems. So we don't go in and say, to have us, you've got to get rid of X, Y, and Z, because we know a lot of systems already embedded, they're loved, they're liked. So what we do and try and do is join the dots and all the multiple systems that are in use. We don't try and get people to take everything away that they know and love, because we know how hard that is. And if you think of big command centers where they go in and you have to really start from scratch, it can take years to get that in. We've got so many tools and integration engines that we can take data from spreadsheet, manually input, all the different systems that we work with, other partners, other providers, to be able to put it in that one place. And it's the visualization at the end for the end user that's the important bit. So you're not having to look at 56 spreadsheets. You're not having to join the dots, interpret it, and we get it live as well. And that's a big bit. You're not looking at yesterday's data. You're looking at what's happening right now to be able to do your job right now, but we're also displaying it back in a way that you can easily understand, so you can get on and do your job, get on and do what you need to do with this data, use it intelligently. And that's essentially what we do. The tech side is the very clever bit. And so we're like two worlds. You've got sort of the operational side, where you've got people who've worked in the industry. We've been clinicians, we've worked in the NHS for donkey's years. So we understand the pains, and we relay that message back to the tech teams to build what they need to build. And I suppose the partnership bit is essential. We don't like to see we're in competition with other providers. We've got over 40 partnerships with other suppliers. We want to work with them, because actually we're not there to replace you, we're there to work with you so that everything's seamless, and that's the whole point of it.
And I think, just to add to that, it's about the single truth and seeing everything on one piece of glass. So, you know, from the InTouch side, we look at outpatient appointments. Well, with COVID, obviously we've seen a massive growth in virtual appointments. So it's about how do we help clinicians and patients, so that whether they've got an appointment, it shouldn't really be differentiated whether it's a video call or a telephone call or face-to-face. The management of that and the experience should be just as good, and that's where we bring everything together into one dashboard.
And what sort of major changes, have you seen over the last year with trust trying to cope with COVID and that shift to?
So from the patient flow side, obviously there's been two elements. And the first one was when COVID first hit. It's how do we change the way we see our patients so that we can keep them socially distanced, we can avoid cross infections as much as we can. So we looked internally, and to be fair, a lot of our customers came to us with ideas as well. So as an example, we had a mobile app, so patients can self-check-in through the mobile phone. We'd always been asked to just tether that to a Trust Wi-Fi. And the reason being is the hospitals didn't want people checking in on the bus, on the way to the hospital, something happens, a turntable, and they go away. So we built our solution to be basically on a Wi-Fi. Then what happened with COVID is suddenly that's completely flipped on its head. And now we don't want people in the hospital, we want them to be outside. So using GPS data, patients can now check in when they're near the hospital, and they can be told to wait outside and then automatically be called in as and when socially distanced and safe space is available within there. So that was the first innovation of how do we manage outpatients during the COVID epidemic.
Yeah.
And then obviously what we're now seeing and being asked for a lot is, how do we deal with this huge backlog? What do we do about that? And so we've come up with ideas of, again, just that digital transformation so that people can access the services easier and simpler and remotely.
Can you give us some examples? Go on.
Sorry, I was going to say half the battle there is understanding the context in which you're working. And I suppose we're now looking at more wider management of those backlogs, where you're looking not just at the acute trust level, but system-wide support, so that you've not got one hospital in one part of an ICS, for example, who's really struggling with their waiting list. And you've got another one in the same ICS where maybe their wait lists are not so long and they've got slot availability. So just having oversight of that and being able to understand what your position is and what your opportunities are is how we come to build Shrewd Elective. So that is allowing sort of system-wide management. So actually it's about that teamwork and being able to work together and not just in isolation.
So if I asked you to look ahead then, because this is think big, act now. Let's take the think big bit for the minute. If I was 3-5 years down the line, what do you reckon will be happening then in a patient? We've been talking about patient flow. Where do you think we could be? Because this is really like, you can push some boundaries here, can't you? So where are we going? What's going to happen down the line?
There is so much out there, and I think that's half the battle. And as I said, my area of expertise is urgent care. Having to learn, when we was asked to build Shrewd Elective, it was, okay, this is new to us. I've had to learn it actually, because we were told we need something. We need to see capacity and demand in real time, each specialty by specialty. But no one told me what data. So I've had to go on the ground, go into trust and actually just walk the floor and see actually what do you talk about every day? What do you need to see? Who uses this? What teams are involved? What systems are involved? And sort of piece it together and understand that journey of the patient, but also the clinicians and those who use the systems. And I suppose I couldn't get over how complex it all was. But I'm also in a very privileged position, we both are, that we also know what's out there. And I suppose half the battle is understanding the art of the possible.
Yeah.
So actually, invite us in, invite suppliers in, and it's not always a sales pitch. It's not always we're trying to sell you something. We'll often go in and say, actually, we spoke to someone down the road, and did you know they've got this great innovation and they've been doing this great pathway piece of work? Do you want us to put you in touch with them? You don't know what you don't know, and clinicians often and managers of acute trusts don't have time to look outside their own organisation. So use the resources around you. Go and see what's going on. Ask us. I said to you the other week, I went and spent a day in a hospital we work with, and we have their data on the system, but I'm the sort of person, I need to understand it more. I need to really get under the skin of everything. So what is it telling me, and then what do you do with it? So when you see on the screen there's a problem, what actually is it making you do?
Yeah.
And I was talking to the theatre management team, I was talking to appointment bookings, I was talking to all the different groups within the hospital. And it was, well, how does that feed into one story? How do you know what's going on over there? And that's just in one hospital. And it was, did you know there's a company that do that? Did you know that they've got this massive app that does this, this and this? Oh, have they? So yeah, I'll give you the information. So there is so much out there, but it's how do we get that message across? How do we make sure as a supplier, how do we make sure the messaging is really simple enough that you understand what it's capable of and how it fits in with whatever the problem is you're trying to solve? That interoperability is essential, because actually you can't, the user, a clinician, and Douglas, you and I both say we're clinicians, you can't have a nurse having to click on that screen for that, something else for that, a spreadsheet for something else. It needs to be so easy for them. And I suppose it's just how we get all these innovations in one place, so that it's that seamless. There's so much out there. Between us, we've worked out, how many products have we got? We've been doing a strategy day to day about how they all work together and what we can do with them.
Yeah, and I think the other thing is as well, there's obviously the issues over the last 18 months have been a catalyst for change. So things like the video consultations, we were working with video consultation providers 2 years ago, but it was such slow progress, and now suddenly, it's taken off. So, some of the things we're thinking about and looking at as partnerships is remote care. How can I, as a patient, avoid having to go in every 6 months for a checkup? If I've got some kind of app that's monitoring my health, then why not use that? And again, we're talking this morning about what's the take-up going to be. And my recollection was having a discussion with an old colleague in a pub about people will never buy the groceries online because people want to feel things. And you know what? It took a while, but now it's second nature. And I think that's going to be the same with health as well. At the moment, there's a kind of a glass barrier there for people adopting this kind of technology, but that's not going to remain.
That's a great point there, Pete. And over to Lisa's point in terms of, as a clinician, so much data is coming. There's a deluge of data. We're swimming in data. How do you go about selecting what data you surface back to the clinician in a dashboard?
It's like I said, it's spending time with them. Understand, what do you need to see to help you today? What do you talk about? So I sat on a few PTL calls and some meetings, and it was just listening, actually, what are the things you need to hear and you need to talk to other teams about, and other companies and private hospitals, getting them on board as well, actually, because you are linking in outside the walls of the hospital. And we then draw that out and say, actually, is this of use for you? What's missing? And again, it's building things that aren't set in stone as well. We can change things like that. And actually, if it's not working, or it's not quite right, or we need to change the layout of something, it doesn't make it an onerous task that's going to take years to do. It needs to be able to be simplified, but really quickly, and adjust. So if we need to have some COVID indicators, that's fine, we'll add them. And it should just be that simple. Pick up the phone and tell us what you need, and we can make the changes. It doesn't have to be a whole industry. So I suppose it's spending the time with them and understanding what they need to do their job, and then we can relay that back into a product.
Yeah, and I think as well, it is about giving the relevant information, because there's so much out there. But another great example, and again something that's accelerated during COVID, is we have a digital pre-op assessment tool. Now, at the moment, most pre-ops are done on paper. The anaesthetist, being very busy, will kind of look at that before they go into theatre. They find something that they don't like, and that theatre's cancelled. So we're extending our waiting list. We're not utilising the resources that we've got because we can't use the theatre. What we're doing with the digital solution is we've got algorithms in the background that work out risks, and we present that right up front. So as a busy anaesthetist, I look at it and I go, there's my risks. I'm happy with that, or I'm not happy with that. Book somebody else in. And it's about giving the relevant information at the right time.
So do you see a massive shift in even more than we've seen, in the amount of time patients will be coming into hospital, or actually more fundamental than that, how big a shift is the change in the interface that's coming between clinician and patient, and their movement around systems as a whole? How big is that change that's coming, do you think?
I think it's going to be huge. I think everyone's getting more aware, and I always preach about this in the urgent care side, of how valuable time is. You cannot afford to waste it with poor processes, delays, patients spending time in the department. It has to be quick. The backlog is there. The only way to get through it is to manage that time more effectively and utilise it as best you can. So if it means you can send an assessment on a mobile app and they fill it in at home, let's do that. There's so many different pieces of improvement you can add to that to save valuable time. And essentially that's about everything we've done. It's because if you don't, then you're inefficient.
Yeah, and the other thing as well, obviously we're all driving to be greener and better for the planet. So why is somebody having to travel 50 miles to do a pre-op assessment on paper when they could just sit at home and do it on an iPad or a smartphone?
And what's getting in the way of us getting down that path, and how do we overcome those things? What are the big?
You said we only had 20 minutes.
Yeah, 2 or 3 things. Go on. That's all you can do.
Change, fear of change, and doing something different. I think I've got more than 3.
Go on.
I think culture and politics, and it's looking at what's available to you. Don't just stick to what don't just stick in your hospital walls. Actually utilise everything available. Understand what's going on around you and what other services there are out there where you might change some pathways. And I think one of my biggest ones, I think people overestimate how much work's involved. We'll always hear, well, our data's rubbish and we don't trust what we're going to give you and we need time to sort it out. No, you don't. Let us in, and that's what we help you with. That's the whole point. Let us in, we'll help you find that data and we'll help you tidy it up. And then we'll give it back to you in a way that's really easy to understand. And I think it's putting the clinicians back at the front of it as well. And I would say that as a clinician, but we often, we see things that are built for BI teams or they're built for execs, but actually what you'd really hope is you're empowering the clinicians to do a lot of this without needing direction from execs and waiting till there's a problem before someone steps in. The early warnings are there, the system's shown it to you, off you go. Get on with what you need to do.
Yeah, the only thing I would add in is the obvious one of finance as well. These things do need financing. In most cases, you can easily prove that it's going to pay for itself, but as we know, that's always a battle with NHS and procurement, and it takes time.
That was so refreshing hearing your perspective as well, coming from sales, particularly the fact that you're reimagining the relationship you as an organisation have with the NHS to say, look, if you've got a problem, we can signpost you. If we can't find a solution, we can signpost you to one of our partners that can help you. I think that is so refreshing to see that sort of approach.
Well, we know we can't build everything. We'd love to, but we can't be the be all and end all of everything. And I mean, we have good ideas.
Yeah.
But then you think, well, actually, we've just learned that someone else has got it. So why don't we just work with them? Don't try and compete with them. Let's just integrate with them and we'll make that seamless. So if it's already in somewhere, we'll just work alongside it. You don't have to reinvent the wheel all the time. It's about collaboration, isn't it?
Yeah, and I think you were talking to Sally Bannister as well about the Think Big project in Dorset. We were lucky, we were, I think, the only private sector company who were involved in that Think Big project and discussion, certainly initially. And part of that was because we were a trusted partner, so not a supplier, but a partner, someone who's trusted to come in and give guidance. And part of that was not us selling our solutions. It was exactly as Lisa was saying, oh, I see you've got an issue over there. Well, we know somebody who can help. Go and talk to these people.
Yeah.
Brilliant. Have you discovered any new capabilities with transformation? As we said, as we've been saying throughout this conversation, the theme is data, making insights of data. So when data traditionally sits in different locations, you smash it together, you can potentially ask different questions of the data. Have you found that you got a new way of doing things, a new added value that you didn't foresee in the beginning?
Yeah, definitely. I mean, the reason we're together physically for the first time in 9 months, because we've never actually met, is, yeah, there's other things. We was having a strategy day to day, looking at, this is our product, but God, we could do something, we could do this with it as well. So the synopsis pre-assessment questionnaire, actually, we could use that to triage waiting lists. We could use that. The same functionalities there. It doesn't, don't need to build anything different, but just use different questioning and the risk algorithms to reprioritize patients sitting on that waiting list. There's so many exciting ideas of what we can collectively do, and maybe just tweak what we thought it was used for just to deliver something else. There's actually quite a lot, and it's been a calming down meeting today. It's actually, yeah, they're all great ideas, but we can only do a few of them at a time.
Don't boil the ocean.
Yeah.
And I'm conscious we've only got a couple of minutes. So we've talked about think big. We've now got to act now. If you had 1, 2 things that trusts should be doing to help address the backlog, what would they be? What would you recommend from your vast experience? My
one is, and I didn't know how to package this up, as I said, when I spent the day in a trust the other week, I come back and I said, if we got an offer on the table where we could just go and walk in a trust for a day, if they invite us in, I'm not trying to sell them anything, but we can just say, actually, we know of this for this problem and this for this problem. We'll map what your problems are, because we're talking to your teams. And we'll just come back with a list of suggestions. Actually, there's this technology, there's this. So I suppose for me, it's invite someone in and get them to walk the pathway, get them to actually take a step back, not people who know and live and breathe it, because we're the same with our products. We know and live our products. And when we're talking about them, we assume we're saying it in a really easy way that people understand, but unless you're in it, so get someone else, take a back step and go and walk it. See where the problems are. Don't assume where they are. See where the problems are and where you might be able to just see some snippets of change. And a lot of it is, there's a technology out there. Yeah. Start to look at it.
Yeah, I actually used to words out my mouth, because I think that's absolutely right. People have to embrace digital technology. It's not going away. They have to do that. And it's about looking beyond, well, that's how we've always done it. And I think we talked a bit earlier about barriers. And that's one, bizarrely, that we still come up against of, so hang on a minute, why do you do that? And the answer is, well, because we've always done it like that. So it's trying to broaden people's horizons. And as Lee said, if one, try to do it yourself, but we're genuinely here to help.
Yeah, yeah. That I think that cuts across everybody, doesn't it? There are so many solutions out there. Almost everything we need most probably exists to solve this backlog. It's about, I think what you're shouting loud is, it's about how we deploy those, how we think about them, how we bolt them together.
Yeah. And it's not reinventing the wheel, is it? Because I think some of the other, going back to one of the challenges, is if it's going to take you 12 months to build it yourself, is it not, especially because of the backlog and as I said, the value of the time essence, why don't you just invite us in? Because it'll take us 4 weeks.
Yeah.
So, use us as an interim solution, whilst if you then want to build something you think is going to be bigger and better, then do it. But actually time is the element right now, and it's going to take you a long time. maybe think of an interim solution in the meantime.
Yeah, it's a good point, and I think we eat our own dog food, as it were, because we know that we're not going to be the experts in every field and build things ourselves, which is why we bring in the experts. So by the same token, the NHS do need to kind of not try to build everything themselves when it exists.
Well, thank you, both of you. Thank you so much for just sort of looking around at both the potential, but also the harsh realities of change, but also what we can get on and actually do. And there's tons of it. I think your message is one of hope, actually.
Yeah,
it's possible, it's doable.
Yeah,
it's feasible.
definitely, absolutely.
Get on.
Now's the time to change.
Pardon?
Now's the time. Use this time to change. Use this opportunity.
Absolutely. And my take home from what you're saying is you're leveraging the best of breed type approach to solving some of healthcare's most acute problems. So thank you for taking us on that whole system journey, and we wish you well for the future.
Thank you.
Thank you both so much. Thank you.
Thank you.
How you guys doing? You all right?
Yeah, Pete and I split up this time, haven't we?
Yeah, I was going to say, are you okay doing that? Or
Yeah.
Was that a conscious uncoupling?
Yeah.
Steady.
He wishes.
that was really good, both of you. Thank you so much. Just to get those reflections. I think it was the degree to which you encourage people to lift up their heads and look outside was really, I think, just invigorating. It was really, really helpful, that because it can be done, and it's triggered all sorts of questions, by the way, so we'll feed through those in a minute. Was there anything, having watched it back through, anything that either of you just thought of and struck you that you just want to reflect back to the audience? That's a tricky one. There you go.
No, my beard's grown a bit longer because I vowed after the Ukraine game not to shave unless it comes home. So that's about the only thing.
I had noticed, Pete.
No, I suppose the same message is there that was there when we spoke recently, and when we filmed that. There's been a few meetings with customers this week where, again, I thought it'd be great if they could see this, and then I'll talk to them again after. But actually, don't overcomplicate it. Actually, it's you assuming things are going to be tougher than they need to be. Just try it, and if it is difficult, we'll work with you to do it, but I promise you it's not going to be. It's getting them over that first hurdle, believing what's possible. And I suppose with the added pressure of the backlog, and winter's coming, so that's going to be another factor back in terms of everything else that's going on. They just feel there's no headroom or space to just free themselves up to work with us. But again, it's you don't need to commit that much time. It's really not as big and as bad as you think it's going to be. So just jump in, go for it. We've got time.
Yeah.
And I think that came up as one of the key things, how precious time is
for
NHS organisations. Very quickly, Lisa, in terms of this whole intimately understanding the pain points. As a clinician, you walk the walk, you talk the talk, and there's something to be said about the resources not being there for, at the moment, we want 50,000 new nurses, all this kind of stuff. Is there a role for informatics to play to help think big, act now? Nurses, doctors who have that idea, what can they do?
I've got a couple of elements to that. So one is from a clinical point of view, it's what tools do they need to be able to do their job, and strategically, what do system leaders need to be able to see to recognise where they can step in and where they might move that resource, because actually efficiency is a better, bigger scale. So actually it is joining up those ICSs and the acute trusts and all the community providers and all the system partners all have a part to play. So utilise them, and if you understand the position everyone's in, that makes it so much easier. I say easier, I know it's no mean feat, but it means you've got more opportunities available to you to do something different. So that's one. But I suppose when we always talk about valuing time, it's not necessarily as a clinician or a tech company, it's as a mum, it's as a daughter, it's as a wife. And actually, we've got so many stories that we've got ourselves and that we know other people have, where actually we have seen and experienced that that process inefficiencies, and where that delay is added on to a week, to a month, to another month. Some people haven't got that time to waste, and it's unfortunate that, you know, we've lost people, and I suppose that's the more important bit here. We always take it back to the patient.
Yeah.
So we want it to be usable by strategic leaders, we want our system usable by clinicians, but actually the most important bit there is the patients. That's why all of you are in this, and why you need to make it better.
Yeah, because people miss out. Other people, if we're not using digital and handling a block of patients over here with digital and easing the pressure, there's a group over here who will never get to the front of the queue, and that's unacceptable to my mind. There's a couple of questions. There's been a recurrent theme in here about a lack of willingness to engage by people in digital, in the need to change, the pain of changing. And I guess the question that's sort of underpinning that is what's behind that? How do we overcome it, Lisa? How do we, and Pete, well, he's just shot off line, but he's left you on your own. How do we overcome that? How do you overcome it? How do you break your way through?
Well, I suppose it's getting the buy-in from everybody and telling them what they can get from the system. So again, it's in terms of BI teams, I've seen that's mentioned on there. One, it's trying to convince them we're not a threat to them, we're not a threat to their role. They sometimes do tell us, actually, we can build this, we can do it ourselves. And we said in the video, actually weigh up how long that's going to take you and what other priorities you've got, and actually use us as the interim whilst you are building something. And you can learn from us, you can see what we've done. We've got 12 years experience and 15 years experience for some of us. Use that. It's taken us a long time to get to where we've got. So use that, it's valuable. And actually, if you partner with us, we can help you, or you can help us enhance our product. And also we can give the data back to you, because often the BI teams we work with are, unless obviously it's within ICS, they're from a particular organisation. And actually that means it's very hard for them to often get data outside of their own four walls. So actually our system is about breaking those walls down. We get that data from every provider in a whole system. So we can give that back to you. So I suppose it's always about collaboration. It's work with us rather than see us as a competition or something you don't like, because actually it's impinging on something you're doing.
Yeah.
And again, it's who are the users? So when the BI teams are creating something, and I have to say we've got so many great relationships with BI teams, and when we're working with some of them, the stuff we do together is fantastic. Some of them have come to work for us, and or we've developed a product with them. So it's not always bad news. But we always say, just work with us and look at who your users are, because actually you have built a fantastic spreadsheet or a Power BI dashboard. It's all the other bits they need that need to go in that as well, which is what we give. So actually we can work together. It's not a one size fits all. We can work together in the same space.
Thank you. Pete, can you see a question come in? Can you see a world where patients only visit the hospital for the actual treatment and everything else is done remotely? Can you see that world coming down the line?
I can't see it in the short term, because we've still got diagnostics and things like that are still going to require that face-to-face engagement. And I do think there is a cultural barrier as well for doing that. And of course, apps that are out there may not be able to monitor everything that requires monitoring. But I do think there has to be a big shift in terms of how many times you need to go to the hospital and when you need to go to the hospital. Without a doubt, it's going to shift. Whether it will turn completely on its head and you'll never go, hard to say that will happen in any time soon.
Okay, thank you.
Great. And we've got a question from a Rob Lambert in regards in time again. We can move at pace, but we do know one of the biggest blocker is the tendering process, the procurement process. Do you have any advice, again, to Pete, about how you avoid some of those pitfalls with mitigating that process of waiting for a long process?
It is incredibly frustrating, and we can only do so much as suppliers to do that. But if trust standing financial instructions insists that they have to go out to tender, there's not a huge amount
Yeah.
that you can do about it. What we have done to mitigate that is engage on frameworks, so especially frameworks with direct award, so that then when trusts have decided that they want to go down a particular route, that vehicle is open to them. But it's quite interesting that that does require something that, you know, certain trusts have got and others haven't, which is strong leadership, so that from the top people say, you know what, I trust that you've made the right decision and we will go with the direct award through that framework, as opposed to, well, we'd better make sure we've done everything by the book and waste 6 months while we go through a tender process. I use the word waste. I'm sure they would say not waste. I'm in sales, but it is always, it's hard. It's slow, but you know what, our best installations are working with really strong leaders. I won't name them on here, but who've actually, you know, grasped the nettle and actually gone ahead, done things, and get the system in really quickly as well. Because if it's about benefiting the patients, then if you waste 6 months in a procurement process, you know, 6 months worth of patients haven't had that benefit.
Yeah. And that's a point you're making about overcoming inertia. It's about leadership, isn't it? It's about the desire to make something happen.
Yeah.
And what do we do? How do we make that really happen? Because we can sit around forever talking about it. Poor old Paul Rylance, you know, he's come back saying, you know, we've tried everything. I don't need to read the rest of the sentence. You know, I can feel his pain sat here.
But I think it's you know, part of the whole, I don't want to go into sales process and things, but part of it is identifying the key people who are the movers and shakers who will make things happen, and it's about showing them that your product is worthy of their backing and leadership to actually support you as well. You know, and the other thing about getting around procurement processes is if your solution is proven to be unique, then again those rules don't necessarily apply. So it's making sure that you're extolling the virtues of what you've got.
Yeah,
great question. We've got another question regarding what advice could you give to healthcare professionals trying to find out what exists out there across different systems? Because I know, as a clinician myself, when you go on, do a Google search, what you're presented back is a plethora of information, and trying to decipher which is real, which is not real. Any advice for healthcare professionals, Lisa?
Well, and we all sound the same. So we come across an article the other day, and it sounded verbatim like what we do. And so, okay, so we spoke to these people, and when they were telling us, it literally was word for word how we would describe ourselves. And I said that's part of the messaging and the simplicity. We've all got buzzwords, and we'll say, oh, we optimize patient flow, but what does it mean? How do you optimize patient flow? It's getting real under the skin of some of that terminology. And I said, there is stuff out there. I mean, we work closely with NHSX, so they've got their playbooks, and we're going to be featured on that very soon. So that, again, they're showcasing, talk to your regional teams. Again, we will work very closely with the E&I regional teams, and I know some of them are putting some lots together about technology out there for different problems. And again, we've been supporting them with that. But again, find someone or these forums here and invite us in. As I said, have a chat with us. We will always free up our time. Send us an email, drop us a message on LinkedIn or any of the social media avenues, and just ask. Just say, do you know who does blah, blah, blah? And someone will always, they won't ignore you. As I said, Pete's our salesman. Pete would never ignore you. Pete would always answer you with an answer. Someone's going to come up and write, yes, he ignored me. So just ask. As I said, it is daunting, and there is so much out there, and trying to read between the blurb and all the everything you say to market something, and talk to other hospitals. Say what, and other systems. What are you doing? What are you using? Who do you recommend?
Yeah, and the ICSs should facilitate that increasingly, shouldn't they? He says optimistically, but that should. You didn't answer there quickly enough, Lisa. There was doubt in your eyes. That should happen, though. It should
happen. I think it's still new, and I suppose the challenge ICSs have when they've got multiple ICPs and acute trusts, they've all been wedded for so long to what they've already got, and trying to convince change to one. And it's not to say you need a one size fits all, as I said, so you don't need every acute trust on the same system. But it's that interoperability, isn't it? At least get them so that they can share the data and it come up somewhere in a story so that they can talk to each other. And I suppose, and again, you should never have to replace everything with that one system that does everything. Actually, it's that interoperability bit. So they've got a very big task on their hands, and lots of BI teams, lots of execs, lots of people who've been in the roles for a long time and in their systems, that they've got to then convince that change is a good thing and actually this is going to help. But you do need to get a lot of sign-offs to make that happen.
Yeah. Thank you. I'm conscious of time. Douglas, was there anything you wanted to pick up? Or...
I just wanted to say very quickly, it was very refreshing having the duo, the dynamic duo, I want to call you to, going through some of these challenges and how you go about finding solutions for them. One thing that sticks to mind, I just want you to just bring it back home, is this best of breed approach. You know, it's just to really put to bed this whole notion of one system that governs all systems type approach.
I'll let Pete have the final word.
I mean, it's really interesting you should say about that, because I think it also feeds into the part of the talk we had where I was saying, don't just assume, well, that's how we've always done it. You know, look beyond that. And even this week, you know, I was talking to clinicians who were saying, well, you know, I can't click on multiple systems. I want everything to be done in one system. So we're not going to take this from you because I want it in that system. And kind of my thought process on that is, you know, if it takes you 20 minutes to do something on one system, but if you made one click, launched another system, and it took you 1 minute, why would you exclude doing that? So it's about really, I think summing all of this up, it's about opening your eyes, look at the art of the possible, and look at where other people, other parties have got a better solution than you've got, and look to people to bring that together.
Good point. Excellent point.
Brilliant. Thank you so much, both of you. Smashing session, really was. Really much appreciated. And I think we've got to go out there now and think about what is possible, and think about all the players are out there, and just think about how do we engage with them and draw them in and use that breadth of offer, because it exists, doesn't it? And you've made that point time and time again, and it's been superb. So for me, thank you very much. Have a great weekend. Douglas, to you.
Well, thank you very much again. Bring on England.
Come on, England.
Yeah. If only Sir Pete can have a shave, and then we're on from there.
Yeah, thank you.
Thank you. Have a great one. Really good.
And
Bye. Really good.
Yeah, a bit difficult to coordinate, because the natural slot for us to go in was taken up with the double approach.
I know.
Yeah, so but,
hey, really good, I thought. Really helpful.
Yeah, I did. It was just that coordination piece that was difficult, but I think we've got some really, really useful insights in there. For me, again, it is this whole system approach, leveraging best of breed, which works for me. You cannot do everything yourselves. Any company coming in and offering themselves as a signposter as well as a solution provider is good. You know, and that's the trust as a clinician I need from suppliers, that if they can't find a solution for me, they can at least point me in the right direction.
And you pick off two issues for me. One is the ability to look up and look out. Yeah, it's so important. Don't look in and look down. You've got to look up, look out. And the other one is seeing your suppliers as partners. I think there was a recurrent theme throughout what they were saying. Yeah, you could argue we're all going to say that, but there was a genuineness about that. And even if they weren't genuine, and I think they were, the issue is that buyers, providers, the trust should be looking for those relationships, because they're more powerful, they're more useful to the trust. Seek to build them, because you'll get a better solution. So that's what stood out for me. Really good today.
Absolutely. And over to your point, the point that was raised about the data, the amount of data that clinicians have to use to make a decision. if you get into your car and look at your dashboard, your car produces so much data now, particularly if you've got one of these electronic cars, e-cars, but it only presents you the stuff that you need to get yourself from A to B. And the stuff that you might want to look at is harder for you to find. It's not in your line of sight.
Yeah.
But what I tend to find as a clinician is the stuff that I need is not front and center. It's stuff that I don't really need as such, operational view stuff, so the fact that they can take you through that journey, they work with clinicians to build those dashboards, to present data that means something to the trust, the ward level, is so important for me. It is because we can't concentrate. You drive a car, people, there's noise in the car. You might have your radio on, you might have the kids in the background, but the dashboards are designed in such a way that you can have all this noise going on and you can still know that you run out of petrol, to turn left, all this stuff to enable you to be safe. Yeah. On a ward where you've got more noise, more disruptions, nurses are still...
And even more data.
They're still working on spreadsheets here, telephone calls over there, ordering, waiting for data to come back to them, nothing in real time. Yeah. But the patient's there in real time with a need in real time. So, it was, really speaking to Lisa was also refreshing. I enjoyed that. I enjoyed that a lot.
There you go.